Mr. Lawton for 5 minutes.
Thank you very much, chairs, and thank you, witnesses, for your testimony. I'd like to start with you, Dr. Maher. Just to put a fine point on this, the MAID regime we have in Canada did not exist as a healthcare policy. It is an exemption to murder in the criminal code. So when you describe mental health as already qualifying people in the eyes of some assessors and practitioners for MAID, you're describing criminal misconduct, are you not?
I absolutely am. I had a patient with schizophrenia who was approved for MAID on the basis of a skin condition that a dermatologist said could be treated with a cream and a sore ankle following not cooperating with physiotherapy after a broken ankle. I had a fierce argument with the MAID provider who said that was sufficient. My patient had schizophrenia and was psychotic and delusional at the time. That is what's happening. These are already happening.
From your understanding of the case of Keanu Vafayan, which was reported in media, would that fit the bill of what you're describing, someone who was dealing only with a mental illness and had a very flimsy physical condition appended to justify MAID?
I won't comment on the particular case. All I know is from the media, but I do stand by my statement. I and other colleagues are experiencing this. People are clearly getting MAID for reasons that are frankly illegal.
We have heard a variety of views from psychiatrists before our committee thus far, and somewhat counterintuitively, we have psychiatrists saying that there's a general consensus that mental health conditions can be irremediable, at the same time as other psychiatrists saying that isn't the case, which proves there is no consensus on this. So explain to me how you view irremediability in the context of mental illness.
I certainly don't view it the way MAID activists have argued, that if you can't, get cure or relief in the moment, that should qualify you. The Benelux countries who at least required standard treatments be tried first is a fine safeguard, but then it begs the question of what are standard treatments. I'm a subspecialist psychiatrist. I'm a psychiatrist. People get referred to me who other psychiatrists say can't get better, don't know what to do, and they get better. There is, irremediable. We're talking not about cure, although I have patients that we could easily say they're cured in the sense that diabetes is cured if you take your medications for the rest of your life. It will have no significant impact on the quality or longevity of your life. So that certainly happens all the time in psychiatry. Do I have patients for whom symptoms persist? Absolutely. Do I have patients for whom symptoms can never be ameliorated? Never, not once. And I stand here representing the 70-act psychiatrists who do this subspecialty work in Ontario. There are always ways to reduce suffering. And I don't mean to be, break the rules of the club, but not all psychiatrists are subspecialists. Yeah. Not all cardiologists are cardiac surgeons, right?
Thank you. When you talk about suicide contagion, I just want to make sure I understand the point you're making. Are you saying that just by the act of permitting this, if that's what Parliament chooses to, well, already has done, but if that's what proceeds, that will basically normalize or legitimize suicide as an option for people who might not avail themselves of MAID, but may just commit suicide on their own because the government has basically said this is a legitimate answer to mental illness? Is that what you're saying?
Yes, the Werther effect, a well-known phenomenon, which is why newspapers agreed not to publish articles about famous people and how they killed themselves. And yet we have made articles in the press daily. I had a patient today, schizophrenia, very, very cavalierly saying if he didn't get a job and a girlfriend, he's going to request MAID. It's been normalized. Suicide contagion is a well-established phenomenon. And we didn't start looking at this data until the MAID legislation, euthanasia program started emerging in some countries. The rates of the countries I named where, their rates have gone up and the countries around them have gone down, it's a very, very legitimate, significant concern. It's modeling, right?
Thank you, Dr. Maher. Just very briefly, Dr. Lyon, when you talk about conversions and people going from track 2 to track 1, The lack of Health Canada having adequate data on that would in and of itself indicate there is no readiness to expand Track 2, correct?
It's a good question. I don't think there's any readiness to expand Track 2. I think that right now, based on my own experience, if we're able to track shifts like that and record deaths that have been moved for reasons such as undiagnosed illnesses, and those are showing up as Track 1 in the data, we really don't know what is really a Track 2 case and what was really a Track 1 case in that. So it would be very, very difficult to expand under those circumstances.
Thank you. Dr. Jacek for 5 minutes, please.
Thank you so much, Chair, and thank you to both witnesses. You've certainly made your positions exceptionally clear on where you stand, and as has been referenced, of course, we have heard from other psychiatrists and experts in ethics and so on, who feel differently. So, from your point of view, Dr. Maher, if MAID were to be approved in our country for the sole underlying condition being a mental illness, what kinds of safeguards could you envisage might be reasonable in such a situation? Or are you completely saying it's impossible to have any safeguards?
I am saying safeguards are going to fail because the cultural ethos, the suicide contagion, is already permeating our society. My teams are pulling their hair out over people planning to refuse medications so they can get MAID, people who have healed and recovered. We're doing suicide prevention, and people are being presented with, suicide is coming. Safeguards, standard treatments being tried that the Benelux countries do, then it begs the question, what counts as standard treatments? Because I'm subspecialist care. I have literally limitless options. And it's because of that my patients get better, because we can continue to try. My patient, the average treatment time for me to help people recover from severe schizophrenia is 3 years. It's not a short process. It's like a long chemotherapy protocol for people with certain types of cancer. How do you maintain hope in the face of that? I have a patient, a family doctor, I'm in the middle of treatment, came and offered her MAID. And she said, oh, thank goodness my family doctor cares enough about me to relieve my suffering. I want to relieve her suffering by treating her. And she was 35. So are there safeguards? Either the fundamental value question here is either you support suicide or you don't. If you're opposed to suicide, if you think the suicide taboo provides protection, if you think there's merit in supporting life, clearly my fundamental argument here is provide the basic services. I work on an ACT team, right? Subspecialist teams caring for the sickest. There are 80 in Ontario. There should be 150 by population. So right now today we have 5,000 people waiting for the care for their illnesses that are degenerative illnesses. They're going downhill, waiting up to 5 years. If I asked you in the cancer field, would you be okay with funding 60% of the cancer centers and letting everybody else kind of flounder and hopefully live? So safeguards, I think, are fanciful given the clinical reality. And this is my great frustration. I can stand here and say to you, you don't get what it's like on a daily basis. I don't know if I'm the only person in the room who spent yesterday listening to a patient in emergency tell me why she took an overdose. I don't know if I'm the only person in the room who has listened to thousands of people after the fact tell me why they wanted to kill themselves and the help they wish they had had. And offering suicide before they get the help,
Dr.
I don't
Maher,
know how you can do it.
I'm sure you're an extremely compassionate physician, but have you not had your own patients commit suicide?
Of course I have.
And
The suicide rate for schizophrenia is 10%. The suicide rate when people are in ACT teams, under 2%. What does that tell you? Like I said, the Harvard stuff, and there's Canadian research, the Canadian Suicide Prevention Society, we know treatment prevents trying again. 4,000 people in Canada will kill themselves this year. Those 4,000 are only 7% of all the people who tried. That means 93% of people didn't try again. Why is that? When you're in crisis, you get the help. What frustrates me profoundly is get the help long before you get to that crisis point.
We had,
when I say,
excuse me.
Sorry.
We had a psychiatrist here who absolutely agrees with you in terms of MAID should never be allowed or considered irremediable unless the person is not in crisis. That obviously, if they're in crisis, this is not the time to make any such a request. Do you think that's at least a reasonable position?
So rational suicide is absolutely a thing that occurs. There's no question. And the majority of people have capacity, right? They're able to make their own treatment decisions. But if you're making a decision at a point in time when you are still suffering and can't get help, or you don't believe that help is going to be possible, or you're fed up and tired of it, I understand that. But look at the 4,000 suicides in Canada this year. 90% will be people with mental illness. 90%.
Thank you, Dr.
So yes, there's rational suicide. But why do we have to help people kill themselves if they can do it themselves? And I don't mean to be callous.
Maher, Mr. Thériault, vous avez la parole pour 5 minutes.
Mr. Thériault, you have the floor for 5 minutes. Thank you, Mr. Chairman. Dr. Maher, I understand your frustration. Mental health, mental illness have often been the poor relatives of our healthcare systems for many years. But other than the fact that I commiserate with your frustration and the suffering you see every day that's expressed before you, what bothers me in your testimony tonight is that psychiatrists who have other opinions than yours are incompetent. I'm not a specialist. I'm not a psychiatrist. I'm not an expert in mental disorders. But it seems to me you have to look at things in a balanced way. We have the Canadian Psychiatric Association. They're not all incompetent people in that association. And now they are making clinical recommendations on MAID, evaluation of irremediable and grave situations of people with mental disorders asking for MAID, and the management of suicide risk during the process for requesting MAID. These people are saying they could provide training on these delicate points that you've raised. They claim that while taking into account structural vulnerability and faced with a case where vulnerability is the main reason for the request, it seems to me that not all the expert groups were full of incompetence. There are people who are saying it's not a matter of continuing the discussion of MAID when there's a suicidal ideation. But I'm sure you've read this report. There were many precautionary principles to avoid the apprehensions you have and the situations you're denouncing here tonight. Who am I to believe? Is anyone who doesn't share your opinion an incompetent, as you have said?
My translation was set up at the initial point of contact, but it's not been working. Donc, je vais essayer de vous répondre.
So I'm going to try to answer. I'm sorry, Madam Chair, one moment, please. Just a moment. We must indicate to the witness there is a way of hearing the interpretation, and I demand that I do not waste my time with witnesses who were not given these explanations at the outset to hear what I had to say. This is the first time that has happened here, but it has happened before. So I would like us to indicate to the witness how he is supposed to listen to the interpreters. We can't have a discussion on sensitive issues like this if we cannot understand each other. So I'm expecting you to stop my time, and I would like to have the interpretation. I will stop your time, and I will explain to Dr. Maher.
This, or do we get the? So
I
on the
understand
bottom
there's
of the
an
screen, Doctor, and we're going to give Luke his time back so he can ask his question again, so you fully understand. But at the bottom of your screen, you can select the appropriate channel for interpretation. Do you see that? You said it at the opening. Joint the audio.
Under audio?
Yeah, and then you can select. What?
Under audio
We'll suspend for a moment until we.
Is it under audio settings?
Here.
Luke, je vais.
Luke, I will give you the floor again. You can put your question again. Okay. Well, since Dr. Maher says he understood, we'll start the discussion with this time with 5 minutes. Yes, we're going to start with 5 minutes. Okay. So go ahead, Dr. Maher, since you apparently understood my intervention. And if that's not the case, I will tell you and we can start over. Yes, you'll certainly correct me.
In describing colleagues. What I said was colleagues who lack skill, which a young psychiatrist would, as residents do. Lack knowledge. I'm not an expert in anorexia. I'm an expert in schizophrenia, bipolar disorder, schizophrenia. So we all lack knowledge to some degree in some areas of our broad area of medical psychiatric care. I also said lack perseverance, and that, I think, is a key point to be made here. I am, as a subspecialist psychiatrist, like a subspecialist in any area. If I have a complicated cancer, I'm off to Princess Margaret Hospital in Toronto. I'm not at my local hospital in Barrie, right? So that's partly what I'm talking about.
Je comprends.
But the perseverance of care.
Alors,
okay.
Vous considérez
Yes,
que...
I understand. You feel that there are people who don't have your skills or competence. I refer you to a document by the Canadian Psychiatric Association. Have you had to do an assessment of a patient who requested MAID?
Est-ce que vous avez suivi
Have you had any training from the Canadian Psychiatric Association when it comes to evaluating the eligibility criteria? Do you feel that this document is full of incompetence? Do you feel that at the outset one cannot assess a patient, according to your view, that it's impossible to do so?
Understanding of the capacity assessment you're talking about. You're not assessing whether someone is eligible for MAID. You're assessing whether they understand and appreciate the consequences of refusing psychiatric care. And if they understand that, they're free to do whatever they want. If they want MAID, they're free to request MAID. The capacity assessment...
Excusez-moi,
I'm sorry, I'm interrupting you, but that's not what the expert group report says. That report indicates quite clearly that it's not because somebody raises their hand and says, I want MAID, that they'll be automatically eligible. They may be eligible, but there is a series of principles and precautions that are stated here and that are considered in the report by the expert group. And therefore, it's not true that it's sufficient to refuse treatment to be eligible for MAID. It's quite the opposite, according to this report. If you're an expert in schizophrenia, or if you cured all the patients who presented themselves to you with schizophrenia, you really deserve a Nobel Prize in medicine. But schizophrenia is a disease that is not easily treated. So it's possible that one patient after 30 years has enough because he has not had his suffering relieved. Here we're saying it's not a matter of saying that a person who is in a suicidal state should have access to MAID. So decision-making capacity seems to be one of the specialties of psychiatrists, and some of your colleagues are telling us that it's totally possible to do things within the rules, and you are claiming that's not possible. But I do agree with you that we need more resources to treat people. We have to be even more proactive. But those are two completely different dimensions. These are two completely different problems. We're talking here about somebody who's at the end of their tether. Are we to maintain him in palliative care forever because that's all you can do, because you cannot cure that person?
You said two things that I didn't say. I didn't say that if you're found capable, you're eligible for MAID. I did not say that, and I am an absolute expert in capacity assessment. So the logical distinction I make is valid, and I am saying the CPA has some things wrong about capacity. And if you look at the capacity literature, you'll only get about 75% agreement. And if you've got 25% of psychiatrists saying capable, not capable, that's a problem. That's an operational problem. So when the CPA says we can do this, it's a claim that is not defensible, because if you're mistaken here, if you say someone is capable and they're not, and lots of people pretend to be quite rational and can manage it for a while, which is why expertise matters, which is why relationship matters. So you've said two things I didn't say. And
Okay, thank you.
In terms of long-term suffering...
Thank you, Dr. Maher. We have to go on. Senator Delphine, pour 3 minutes.
3 minutes, Senator Delphine.
Dr. Maher, I'm interested in data, and you referred to some data, but I would like you to provide me support for it. You said 93% of psychiatrists are opposed to MAID for mental illness. Where do you get that number, 93%?
So that was an OMA survey, and 90% are opposed without standard treatments at least being attempted first. We don't know, as far as I can tell. There's no recent data saying what the absolute opposition is because there have not been continuing surveys. And the data I provided about Canadians being opposed, that was an Angus Reid survey.
Okay, so but you said 93% of psychiatrists, not Canadian. So I mean people that are that are supposed to be able to evaluate or assess capacity. So you said that number is coming from a survey?
Yes, the Ontario Medical Association survey.
Okay, so could you provide...
And so a survey is never everyone.
Okay.
It would be hundreds of people who responded.
Okay, could you provide a link that we could have access to that survey?
Certainly.
And I understand from your answer that the survey was that they should not have access to MAID unless they have tried things. Isn't that what you said?
Unless standard treatments have been provided.
Okay, so and what is the question? What was the answer about the question? If standard care is provided and treatment for a few years, what was that asked to the psychiatrist that if they are still opposed at that time, access to MAID?
No, it wasn't asked, but the question was asked: how many people support MAID for mental illness, and the answer was only 3%.
Okay, without the treatment, and you said that. The other thing is that the rate of suicide is increasing in jurisdictions providing access to MAID for mental troubles or illness. So which data are you referring to?
There have been about 5 studies published at this point. Jones would be one of the obvious authors, has done research on this. And it's recent research because it was prompted by MAID and various countries starting euthanasia programs. So it's solid data.
So would you mind to provide us the copies of these 5 studies you rely on?
Certainly, happy to do that.
Thank you. Do you have time or?
You have 24 seconds.
Well, then I thank you very much for your answers.
Senator Martin for 3 minutes.
From my mic, but I'll turn it on. Thank you both for your testimony. My first question is for Mr. Lyon, Dr. Lyon? Dr. Lyon. So you explained what happened to your father, and I think it's important for us to understand what happened. And you said your family had difficulty getting MAID clinician to consider the collateral information you tried to share about your father's mental illness. So based on this direct experience, can you tell us what that revealed to you about how the current system handles mental health evidence, and why should that concern this committee as it's examining whether or not to expand MAID for those suffering from mental illness as a sole underlying condition?
So my impression from that experience was that the providers in question, I got conflicting answers. So his MAID provider seemed to suggest that his suicidality was a reason for MAID. And the conversations we had, as I mentioned, she suggested that, he might just kill himself without MAID. Suicide is more plausible now, things like that. But then when I had broached the prospect of his depression, she also told me that if he had depression, he would be ineligible for MAID. So there was I didn't quite understand that conflict in those comments between, okay, if he's got depression, he can't have MAID, but, it's okay to be suicidal. So if you look into the way that the Right to Die movement frames this, they have this idea of rational suicide, and they'll start to make a separation there. But then when it came to a psychiatric assessment, his provider said that the psychiatrist would just agree with them, but the psychiatrist also said it talks about his depression in the assessment, but it said it sort of quotes my father saying something to the effect that it's very minimalizing language, right? And then it goes on from that. But the assessment itself has been described as global to me and subpar. So there was this almost a conflict between what the psychiatrist was exploring and then the different statements that his provider said to me. So it was very confusing. And so when we look at MAID for mental illness, you're going to get divergent views among individual clinicians. And when I think about, as the law is written now, as I understand it, if it comes to pass in 2027, it won't be psychiatrists doing the assessments for mental health cases. It will be the same nurse practitioners, general practitioners, anybody else a medical practitioner or a nurse practitioner who is able to do these assessments without any training as it is. So when we move into that space, we don't have any coherence.
Thank you,
Yeah, so
Dr.
that inconsistency.
Lyon.
Thank you.
Senator Martin, I'd like to welcome Senator Lafreda to our committee, and you have the floor for 3 minutes.
Thank you, Mr. Chair, and thank you to our doctors, our experts for being here this evening. So my question is around defining incurability in mental illness, and Dr. Maher, you went deeply into it, and I'd like to have Dr. Lyon's expertise on this if we have time. There remains significant disagreement as to whether and how a mental disorder can be considered incurable. I mean, that's a very important question. And does the current, maybe elaborate on this, does the current clinical and legal definition provide sufficient clarity to ensure consistent assessments, or does it risk subjective interpretation that could lead to uneven or unsafe application? And I say that, and I put that question forward because, Dr. Maher, you made some serious claims there with respect to suicide or mental illness, if they were allowed or not allowed to it. And I come from an industry where integrity is never negotiable. I think I've said that a million times. So, but we don't have any doctors that were reported or what have you. So, how much? Maybe you have your opinion on that, or your judgment on it. More importantly.
You're asking me?
Yes, Dr.
Excuse
Maher,
me.
go ahead.
Yes, I tried reporting a doctor to the college of one of the provincial colleges and was told, until the patient is dead, there has been no malpractice. And I said, the assessment has come to a conclusion, the doctor has come to a conclusion that is flat out illegal. There were no criteria on any stretch of the imagination that would qualify this patient for MAID. The family doctor and I both told the MAID provider this. And the college said, until the person is dead, it's not malpractice. And I said, well, this person is being induced to a suicide plan, has been given the belief that they will be killed, and they were offered their date to be killed. And the college said, we will do nothing. So I have tried, colleagues have tried, and that's what we hit our heads against. So you don't, you believe the tools, protocols, safeguards in place are faulty, or they could be improved in making the distinction? I am aware of murders that have taken place in Canada for which there was no follow-up. The police have the door shut because the hospitals say it's confidential medical records, and the college, I won't say all colleges, but in my experience and other colleagues, there is not action. There is not a taste for this. Yes, I'm aware of homicides.
That's very concerning.
Sorry,
and it's even.
You only have about two seconds left. So
2 seconds.
If you don't mind,
I don't have that much talent. I work hard every day, but
so unless you drink lots of coffee, you're not going to get it in there in time.
Thank you.
So, Senator Wallen for 3 minutes.
Thank you very much. My question is for Dr. Lyon. I read from your professional credentials that you are with the Department of Environment and Geography, and you also work in the field of biodiversity. Is that correct?
That's correct.
Do you have any formal legal training or training in policing or in constitutional law?
No, I don't.
Okay. The reason I'm asking is because you've authored and published a paper called Canada's Medical Assistance in Dying System Can Enable Healthcare Serial Killing. That is a very serious allegation to accuse medical professionals of being serial killers. What was that professional opinion based on when your area is neither medicine nor law?
Several things. So one thing one thing I am is a researcher. What I can do is research. So when we look at the definition of serial killing that law enforcement services put out, it's quite simple. It's usually something along the lines of killing 2 to 3 people in sequence on separate occasions or separate events. That's serial
And you
killing.
think that is applicable in the medical profession?
When we create it, so the difference between let's say criminal serial killing and MAID is that we've created a carve out in the criminal code for medical professionals who engage in discrete.
No, there are
homicides.
standards and eligibility requirements
Let me
for the
finish,
provision
please.
of MAID. There's no such situation for serial killers. I mean, let's be realistic here.
So what you're speaking about there is basically a definition in law. Okay, so criminal serial killing is killing outside the law.
Right, and this
When
is
you're
not
killing in
outside
MAID,
the law,
fitting
which is the
definition of
distinction I'm
serial
trying
killing,
to make clear here for
you
people
are
because
creating a legal form of serial killing in MAID because you're creating an opportunity
MAID is
for
actually
MAID
legal, right? You understand
Yes, it
that
is.
according
I'm saying
to the
you're
Supreme
creating
Court?
a legal form of serial killing. What I'm not saying right now in MAID is serial murder, which would be illegal. So in serial killing, MAID is still a form of serial killing. So if you kill 1, 2 to 3 or more patients sequentially within the law, you are still committing serial killing within a legal parameter.
So if you
by that
misdiagnose a person, or if the cancer moves more quickly, or if the mental illness can't be diagnosed, you're saying any medical professional could be actually accused of this. That's your position.
That's not my position.
Well, there's a MAID is actually legal in Canada. It was
I know,
declared
that's what I'm
legal by
saying.
the
It is
Supreme
still-
Court and Parliament.
If you take the basic definition that law enforcement uses for serial killing, before you add whether it's criminal or not, either whether it's within the law or not, you're talking about the difference between a culpable and a non-culpable homicide. MAID legally is a non-culpable homicide. So a series of MAID deaths that are within the law are a series of non-culpable homicides.
Thank you, Dr. Lyon and Senator Wallen. Senator Wells for 3 minutes.
Yeah, I'm going to continue what my colleague has just been talking about. It's both of our witnesses today have made some pretty serious accusations of doctors being murderers. This is, if this is so extreme, the committee needs to see proof before those accusations can be part of the public record. So I'm just going to put that out there. Dr. Maher, are you aware of the 2026 Environics poll for support of MI-SUMC? The poll question states, under Track 2 safeguards, do you support or oppose allowing an adult with the capacity to provide informed consent to seek an assessment for MAID, and if eligible, receive MAID when their only medical condition is a severe treatment-resistant mental illness that causes enduring and intolerable suffering? Are you aware of that poll?
I'm not.
Okay.
So I'd like to clarify.
Thank you.
I didn't call anybody a murderer.
Oh, thank you.
Homicides.
That's not my question. Right now, the poll, so 80% of that poll agree with that assessment, agree with that statement. That's public opinion. That's actually on the record. You've also said in your May 2022 testimony before this committee, you stated, we have yet to find a case where treatment and recovery were not possible. Yet we've heard from multiple witnesses at this committee that we should treat persons with a mental illness similarly to how we treat persons with disability. Understanding that, is it your professional opinion that all people with mental illnesses will get better?
No, it's my understanding
thank
that
you.
all people with mental illness can have their suffering reduced.
Thank you.
And can be supported
My
to the
time
point
is
they're
limited,
no longer
unfortunately.
suicidal.
I think you posed a very lengthy question. I would give the witness a brief opportunity to reply.
It was
to
a
the
yes or
question.
no question. Thank you.
No,
Chair,
we're
gonna
not going there.
point of
Dr.
order?
Maher, you have 10 seconds or so to answer the question.
Thank you. I'll just repeat my answer. Suffering can be reduced, and people can receive treatment that can reduce their suicidal thinking, goals, and plan. They can find meaning and purpose with support. And yes, that's true of 100% of people.
Thank you. Dr. Lyon, so my question is, have you ever personally assessed a person for MAID?
No.
So what you're sharing is your personal position, which seems to emphasize protecting vulnerable individuals. But how would you respond to concerns that denying access to MAID for competent adults is inherently paternalistic and undermines their autonomy and dignity?
I've never made that argument here.
I'm asking you how you would respond to those concerns that we've heard before this committee.
Well, MAID came about through Carter, so it's a constitutional decriminalization, basically, right? And then we have this lower court ruling in Quebec. So within those parameters, and the parameters set out in the legislation, provided those are met, that there's not much room for argument on that. If I have a personal opinion on what I think is happening, if that's what you're asking me for.
Okay, thank you. Sorry, we don't have time for that personal opinion, but Mr. Cooper, you have the floor for 3 minutes.
Thank you, Mr. Chair. Dr. Maher, just to follow up, you indicated that a 35-year-old patient who had severe mental illness was offered MAID by a family physician proactively. What happened to that patient?
She died of an unexpected medical condition before the MAID date.
Okay. Now, I want to follow up.
But she had purchased her ticket and was ready to travel, and her parents were going out of their minds.
Okay. Now, you you indicated that you are aware of and you have reported homicides that were carried out under the guise of MAID. Can you elaborate on that?
So I haven't approached the police. I have dealt with one college in particular. I also sought the assistance of my professional association's lawyer, and was surprised to discover that the Canadian Medical Protective Association now has 4 lawyers whose only work is to deal with MAID issues that doctors keep bringing up for them. The restrictions on what we can do, given the limits of confidentiality, are extreme. And the best I could do was go to a college.
And when you went to the college, what happened?
As I said previously, I was told until the patient was dead, there can be no malpractice. And the clear tone of the conversation was, we're not going to do anything about MAID because the legislation is so broad that it really is a matter of individual clinical judgment whether someone thinks that the criteria are satisfied. And because it's a subjective standard, no objective standard, if someone says they've suffered enough, that's enough.
We've heard in this committee documented cases of abuse under the MAID regime that have been cavalierly dismissed as anecdotal. What do you say in response to that?
Well, I'm not talking about anecdotal experiences myself. These are direct experiences with MAID impacting my patients, impacting my teams. And it's not even legal for mental illness yet, and it's already had profound disruption in terms of undermining our efforts to maintain hope and to provide treatment for recovery. It gives people the message we've given up, right?
14 seconds.
Can psychiatrists accurately distinguish between suicidality and a rational request for MAID, yes or no?
Suicidality and a rational request for MAID. No, MAID is suicide. It's taking steps to arrange your own death. MAID is suicide.
Thank you, Dr.
It's an artificial distinction.
Thank you, Dr. Maher. Ms. Koutrakis for 3 minutes.
Thank you, Mr. Chair, and thank you to our witnesses for appearing before us this evening. My question is to Dr. Lyon, and my understanding is that you do research also internationally. So I'm interested to know, when you're doing your research across, how assisted dying develops across different countries, could you walk us through a specific example where eligibility expanded over time and what actually drove that change in practice?
I don't do research across jurisdictions on MAID. I focus mostly on Canada. So there's been some work on the Netherlands, for example, and Belgium. I think people like Trudeau Lemons or Scott Kim might be better placed to answer how those systems evolved.
And in your research in Canada, have you seen or heard any professionals talk about safeguards that may have looked strong on paper but didn't potentially do what it was intended to do if put in practice?
I think quite a few of them have come before this committee.
Dr. Maher, do you have something to add to that? Through your experience, your practice, what you have seen through your patients or research data?
In terms of expansion to other countries?
Yes.
Well, I've been involved in conversations with people in other countries many times looking at these issues. If you're asking why is it expanding, some of the more interesting questions is why doesn't it happen in any of the Asian countries because of the values and perspective they have there? Why was it recently overturned in Slovenia? Why did the Scottish Parliament object? Why have we seen the kind of the chaos in the British discussions over this issue? It's a values question. I think fundamentally you either support suicide prevention and helping your citizens live and heal and recover, or you don't. And so I've little more to offer than that.
Because I was touched personally by someone's story where their parent became blind and deaf and had requested, this played a huge issue on their mental illness, and they had asked for MAID, and it was rejected. And as a result, this person took matters in their own hands, and they jumped off a balcony. Would you agree that every Canadian deserves a dignified death?
Yes, but we have different definitions of dignity. Yes, but we have different definitions of dignity. The greatest dignity is to have your autonomy restored and to be able to continue to live. The argument that somehow a messy death justifies supporting suicide misses the point completely. What it justifies is treatment to prevent getting to a messy death or MAID in the first place.
Thank you, Dr. Maher. Mr. Thériault, 2 minutes.
Mr. Thériault, 2 minutes. Mr. Thériault, we cannot hear you. I'm used to being in the room. My question's for Dr. Maher. In bioethical literature, there is history about end-of-life care. We went from over-treatment to recognition of right to die, because palliative care is a recognition of the right to die. We used to call this passive euthanasia, and we heard about the same arguments about passive euthanasia as what we're hearing tonight. So we went from medical paternalism, which imposed over-treatment, to recognition of right to die for the patient through palliative care. It was recognized, therefore, that a patient could have care for comfort, and a little later we arrived to MAID with the respect for autonomy that we wanted to give patients. A patient can decide on their own death in a situation where they're terminally ill. I hope you're for that. So that respect for autonomy and self-determination of a suffering person led us to sound medical practice, which consists in recognizing refusal of vital treatment, cessation of treatment when it's futile. So I'd like to know, what do you feel about end-of-life care, medical paternalism? And you seem to feel this way, at least when it comes to psychiatry.
Right. So I'm one of the earliest formally trained bioethicists in Canada, so I know the literature well. And I've watched the pendulum swing around paternalism, and I have greatest respect and gratitude for that. We should be free to make our own decisions. And here's what it comes down to. I am free to kill myself. Why am I entitled to ask anyone else to do it for me? And if you say, oh, we have to provide compassionate care and support, I know patients who bring their families to their home with planned suicides, and they don't need a doctor to do it. So there's some sort of artificial claim here that when we bring a doctor in, it makes it better or prevents errors or all of these things. The paternalism here is saying you have to have a doctor to do it. But let me make this critical point. If you're not willing to kill yourself without a doctor helping you, that means the doctor is responsible for suicide inducement.
Thank you, Dr.
It is
Maher.
facilitation.
Thank you, Dr. Maher. Senator Martin for 2 minutes.
Okay, not much time. So you were talking earlier about just the concerns that what gets called autonomy can sometimes be a response to abandonment, poverty, isolation, and lack of support. So this is a question to Dr. Maher. If assessors are already being trained to focus narrowly on consent and capacity, how can Parliament trust the system to safely handle cases where mental illness will be the sole underlying condition? So would you further expand on your sort of what is happening right now with the system?
Certainly, it's a nuanced discussion. We treat people like they're Mr. Spock in the literature in our discussions of capacity. They're not. They're messy. They're driven by emotions and despair, hopelessness. The very offering of MAID is a message in that point in time that I haven't got anything else for you. So the undermining of the clinical relationship by the very offering of MAID is profound. And unless you're living it and experiencing it, I'm not sure how to communicate what it means to rob people of hope, especially when they're having to struggle over time. Monsieur Thériault talked about, am I going to make somebody suffer for 30 years? If they've lived for 30 years, they've been living a life. And what has that life been for them? So to say that they shouldn't have had those 30 years, they made a choice to live. Autonomy is my choice to do what I want with my body. I can kill myself. That can sound callous, but it's not. People thoughtfully plan their own deaths. I can tell you stories of how people plan their suicides. And if you have some fantasy that everybody does this horrible, impulsive thing, it's uncommon. It's about 10% of people. And to be clear, the impulsivity is not genuine impulsivity. They have rehearsed it in their heads for months. We have research showing that. That's autonomy. I can do what I want. I'm objecting to the system being set up to induce, to seduce, to invite, and to rob people of hope. That's not what we as a country should be doing to the vulnerable.
Thank you, Dr. Maher. Last of all, Senator Lafreda for 2 minutes.
Thank you. So, Dr. Maher, thank you. We don't want to rob people of hope. We all need hope. But my question to you, and Dr. Lyon, if you'd like to bring in his expertise, if we do have the time, given the inherent uncertainty in these assessments, would you agree or with an additional national safeguard, such as a mandatory specialized second opinion to ensure consistency and protect the vulnerable individuals? And I think data oversight and public confidence are so important, and public trust in this regime depends on transparency, consistency, and the ability to monitor outcomes in real time. The current data collection, what I gather and what I've heard this evening, is not sufficient enough to capture the complexity of these cases, including the unsuccessful requests, the reasons for refusal, and indicators of vulnerability such as lack of access to care or social supports. I mean, what's your experience and judgment on that?
Psychiatrists have biases. There are reasons that some psychiatrists are strongly in favor and happy to do MAID assessments. We come with biases. If you're asking what the data says about capacity assessments, it's very easy to sort out who's extremely psychotic or profoundly depressed. Very easy. It's very easy to sort out who's doing really well and is quite capable and rational, which would be the majority of people. right? What's complicated is the gray zone, and the gray zone is substantial because the data will say about 75% of psychiatrists will agree on what they're seeing. And if you have 25% disagreeing, that's pretty significant. I frankly view the capacity issue as a red herring. I've thought this for a long time. People are focused on, we got to decide whether they're able to decide. That stuff is done every day in psychiatry, every day, and it's called a capacity assessment for treatment decisions. And insofar as you're calling MAID a treatment decision, then this fits into that category. To say it's somehow special or different is, in fact, does not reflect the reality of the day-to-day work of mental health care. Are people better at doing capacity assessments than other people? Absolutely. I have, if I've got 40 years of experience versus I'm a fresh grad, I'm going to see things differently.
Thank you, Dr. Maher. Thank you, both Dr. Lyon and Dr. Maher, for your time. We'll briefly suspend while